So Renee, I don't know, about a couple of weeks ago said, I need an old person to talk about the history of BPH research, and you've been around forever. So you're going to hear just really a few thoughts on what's been going on and how things have changed over the last 40 odd years. I don't know how I minimize. Oh, hang on. Sorry, that's better. I had pictures of everybody over the top of my slides, which was a bit disturbing. Okay, so anyway, I'll sort of do this. This is really kind of put together as a kind of bunch of potential discussion points and some items of perhaps historic interest. So feel free to interrupt, or you can wait till the end, and then we'll talk about things of interest at that point. So well, that's okay. Well, if I click on it, it works. So I thought perhaps I'd start off by thinking about um, what we really need, and I think perhaps the biggest issue in BPH treatment over the next few decades is a combination of one, a growing population with more need for therapy, and two, a population of urologists who's growing more slowly than the patient numbers. What we have are some relatively ineffective medical approaches that have been largely unchanged now for about 3 decades. And really, I think we need new and efficacious medical approaches that slow the flow of patients to doctors, preferably drugs that can be prescribed and monitored, perhaps by internists or family physicians prior to the involvement of specialist urologists. I'm not really going to talk about surgery because Alex Glasser, I'm sure, is going to be talking about that next month. I'll mention a couple of points, but that's about it. There's been a lot of developments in surgery, and well, you might as well hear about that from someone who actually knows what they're talking about as opposed to from me. So over the last 4 decades, the presentation and the age profile of these patients has been pretty much unchanged. It's this BPH is still the most common symptomatic tumor-like condition in humans. It's not really identified histologically in men under the age of 40, but the incidence of the condition increases rapidly with age, as I think we all know, to include the vast majority of men by the age of 80. And Pat Walsh, writing in 1984, mentioned that, while the estimates vary, the number of men who at that time required surgical intervention was probably about 30% of the total men over the age of 60. That may have changed somewhat given the move to medical therapies in the intervening period, but it's still a lot of men who need treating, and many of those who end up getting surgeries. So historically, what have we known about the prostate? Well, we've known that the prostate is linked to testicular function, and I wanted to know what I was thinking about on this 40 years ago. So I actually went back to the background section of my PhD thesis and looked around, and one of the things I found was this quote from John Hunter, who talked about the changes that castration induced in the prostate and Cowper's glands. I do note that from this quote, the practice of tasting secretions seems to have dropped out of favor, at least in a professional context. And it's also noticed that he did at least recognize that there is a perfect male, and I think that's a recognition that's also disappeared somewhat from the popular imagination. But Hunter was an amazing anatomist, and was actually working next door to the building that I was working in the Royal College of Surgeons. In Lincoln's Inn Fields in London. At the time that I wrote this, he had been working in the building next door. If you're ever near the Royal College of Surgeons, the Hunterian Museum, which is named after John Hunter, is just a great museum of surgical oddities and samples and things. And if you go and bang on the door and say to the security guards, "Oh, I'm a researcher with an interest in whatever," they'll generally let people in to take a look around. So it is one of those sort of off the normal tourist track little things that's actually worth doing in London. I'm not sure I'd take my kids around, and I'm not sure they'd allow me. Well, my kids now are adults, but I'm not sure I would take small kids around. and I'm not sure that they'd allow you to, but it is a worthwhile museum to look at. So if you remove androgenic stimulation, you can see that basically men don't suffer from prostatic enlargement. And Zuckerman, writing in 1936, talked about this Russian sect in which the men underwent ritual castration at 35 years of age and didn't get any prostatic enlargement. And there's also studies from the 1940s looking at the absence of testicular function, either from castration or hypopituitarism, which prevents the occurrence of BPH in men living into older age groups. This was based on a post-mortem examination of patients, and they found no histological evidence of BPH. There's also Chinese court eunuch data, which also basically backs up this point. So you need testicular function to get BPH. I think that's pretty much where we were. So other old ideas, well, the T to E2 ratio. So Gene Wilson, who was at UT Southwestern, was the discoverer of 5-alpha reductase. Working in the 1970s, came up with this idea that as men age, the levels of testosterone decrease and the estrogen levels increase. So the T to E2 ratio changes, and he hypothesized that this resulted in BPH pathogenesis. I mean, one of the issues with this interpretation is that these changes occur somewhat late in life to be triggering these events. Another old idea out of Stanford was John McNeil and the idea of embryonic reawakening. So John was working in Stanford in the 1970s and 1980s, and he suggested a reawakening of fetal inductive potential in adult mesenchymal cells of the prostate, giving rise to new growth and duct architecture. And there's actually interesting histologic and to some extent experimental evidence. This was an idea we were very interested in when I was in Jerry Cunha's lab back in the early 90s, as something that might be an explanation. But again, we have no sort of real idea of what the underlying process is here. Less old ideas include inflammation. I mean, BPH has been associated with inflammatory comorbidities such as metabolic syndrome, type 2 diabetes, obesity. Inflammation is very common in foci of BPH, and it's also linked to therapy resistance. Wade Bushman and Travis Jerde at UW-Madison suggested a role for inflammatory mediators during prostatic development, and then suggested that those cytokines and chemokines disappeared, but then reappear in BPH. And Renee has also produced work that underlines the links of BPH to autoimmune inflammatory diseases. So, inflammation is certainly something that's potentially out there. So, what do we know? What does this summarize to then? So, androgens are important, but then again, high androgens in young men don't cause BPH. So, what are androgens doing? You need them, but you need the right amount. Estrogens might be important, but despite the fact that I've been told that SERMs are the next best thing for quite a long time now, they never seem to quite work out. Inflammation might play a role. It's a possible intervention point, but NSAIDs don't have lasting effects, although biological agents might. Developmental pathways may play a role in driving new ductal architecture, which might provide additional targets, but those aren't likely to be easily and cheaply druggable. And we still don't really understand why this happens. So what do we need to do? I think. So what do we do? I guess I think the history is that there's been a range of surgical approaches. I mean, it's certainly clear that untreated severe BPH can kill you, and it may still result in more deaths worldwide than prostate cancer. Treatments are clearly necessary. Men who go into complete urinary retention don't have a long lifespan. Surgically, this has been kind of treated with castration, again, removing androgens. This was done in the 19th century and in a small study by Charles Huggins in the 1940s. not a wildly popular approach, but I guess if your choice is that or death, that's kind of where you come to. Simple prostatectomy started in the late 19th century, and I really wouldn't have wanted to be on the end of that at that time, and um, became more common and of course less dangerous by the second half of the 20th century. Transurethral resection was introduced in 1909 by Hugh Hampton Young at Johns Hopkins, and at that point it was really just blind scraping on the inside of the prostate, not really knowing what you were resecting. But it's undergone many, many technical developments with improved efficacy and safety through the 20th century, and at one point became the most common surgery in men in the late 1980s. So now there are a plethora of new techniques which are coming online, and these developments are going to be discussed at the next meeting of this group. So I'm not really going into that. I'm just giving you a little taste that people have been kind of trying to intervene surgically in this for a very, very long time. Medical approaches, well, alpha blockers are widely used, still have a long history. They started in the 1970s with non-selective alpha blockers. Um, Phenoxybenzamine works apparently, but it drops blood pressure drastically, so patients end up falling over a lot, and it was linked to mutagenesis, which doesn't make it really great. In the 1980s, we got short-acting selective alpha blockers. So prazosin was apparently effective, but it required twice daily dosing, which is a bit suboptimal as far as patients and patient compliance is concerned. Longer-acting alpha blockers, taurosin and doxorubicin, with daily dosing, came in the 1990s and were the basis for trials such as the MTOPS trial. And in the late 1990s, we got these uroselective alpha blockers such as tamsulosin or Flomax, which are currently used. So these are effective in some patients with relatively limited side effects. And in more recently, PDE5 inhibitors have also been shown to be somewhat effective again. But again, you're targeting muscle tone in these patients. You're not really getting to any particular new pathways. So a line of drugs is essentially targeting the muscular tension in the prostate. The other major medical approach that's been used uh, since the 1990s is 5-ARIs, which were developed particularly by Russell at UT Southwestern. They were introduced in 1992, and the issues include a side effect profile which makes them relatively unpopular with many patients, including erectile dysfunction. But it is the most effective approach we have right now to shrink large prostates, unless you want to get back to something like surgical castration, which has even worse side effects. So there are medical approaches, but they haven't really developed over the last 30 years, and I think this is the area where research can kind of move forwards and perhaps give us some insights. So what's newer? So, when I first started working in this field, people recognized BPH, and it was basically enlarged prostates. I think there's been a recognition now of subclasses of disease, notably larger versus stiffer prostates, and the role of fibrosis in prostatic symptomatology. With a recognition that these might require different clinical approaches. Does size matter? Does stiffness matter? I mean, how do you approach these? How do you approach these things? And I think one other thing that's improved a whole lot since I came in is just advances in imaging technology. We can now determine prostate size relatively accurately, and we're starting with MRIs to move towards visualizing and getting accurate visualization of inflammation and fibrosis as processes that are occurring in vivo, which may give some insights into appropriate therapies for individual patients, which may be a very useful way moving forwards. Models, well, models have changed. There's been numerous new mouse models that have been developed and characterized to different levels over the last few decades. And generally, they've focused on specific interests of their originators. So these could be inflammatory pathways, these could be diet-related pathways, high-fat diets, for example. T plus E2 models. I saw Will was on the call, and he's done a lot to move those models forward, and they all have their strengths and their weaknesses. Overall, I would say they haven't been as well correlated with human diseases as study sections would like them to be, and that's kind of the focus of our P20 group, is to try and line these things up, because we're all fed up with being told by study sections that we're using the wrong model, but with no particular advice on what would be a better model to use. I think the development of three-dimensional in vitro approaches, notably organoid-based approaches, is giving us some new models that I think are going to prove informative over time. And we still need to understand human disease and diseases to see how our models fit, and how they can be useful, how our tools can be useful to interrogate the disease process. Um, I think we've seen major improvements in cell characterization. I mean, this is still not complete, but notably single cell RNA-seq and spatial transcriptomic approaches, and combinations with immunohistochemistry as well have been useful. We've done some of this. Doug Strand obviously has done a lot, and many of you out there have done different things in this world. I think this needs to be expanded to include a good representation of all of the major BPH related disease profiles. And we need to understand the role of these cell types in the context of the overall patient environment. What does age do, and how does that change how a particular cell works? What is a cell doing in the context of a diabetic patient, or of an obese patient, and how is that different from in the context of a normal patient, or a patient with a different profile of comorbidities. So what are the problems? Well, one of the problems I think that we're already starting to deal with, and it's only going to get worse, is that the changes to surgical procedures have generally tended to move in the direction of destructive approaches, which is going to have major implications, I think, for future studies. It really underlines the value of our existing biobanks, and the need, I think, to bank tissue into the future, because it may be that we end up not seeing a whole bunch of tissue. If everybody's going off and doing green lasers or aquablation, we're not going to have any tissue available to actually do research uh, for, and so perhaps more comprehensive mapping and spatial transcriptomics studies, as I said before, across a range of disease states, really are warranted in the short to medium term, because they may not be possible in the long term. And that's, as I say, probably a subject for discussion with surgeons. If they're destroying all the tissue, it's going to be difficult to understand the disease. I think that sort of underlines the need to develop a more reliable in vivo, ex vivo, in vitro, and potentially in silico models to study